Okay, good morning, everyone. Welcome back to our course unit. My name is Toki Simon James, and today our lecture 2 will be on capacity planning in healthcare. First of all, our learning objectives. By the end of this lecture, you should be able to understand the concept of capacity planning in healthcare, identify key factors that influence healthcare capacity, learn how to collect and analyze historical data for capacity planning, and explain the King theory for capacity optimization. Capacity planning in healthcare is a complex and challenging task that involves balancing the demand for services with the available resources. The goal is to optimize the utilization of staff, equipment, and facilities while ensuring high quality care of patient satisfaction. So the point here is that when you talk of capacity planning, we are looking at both aspects. Okay, it is the staff and even the equipment and also the facilities that you have that we need to use to be able to deliver the quality needed for patient satisfaction. Capacity in healthcare refers to the ability of the healthcare capacity, facility or system to provide care, treatment, and services to patients within a given period. It involves the allocation of resources to meet patient demands efficiently. Measuring hospital capacity. How do we measure the hospital capacity? There are techniques we used. Number one is the bed occupancy rate. For most of you who had been in the clinical practice, this is not a new word for you. Bed occupancy rate is the percentage of available hospital beds occupied by patients at a given time. And we have a formula for calculating this. The formula is given by the number of occupied beds divided by the total number of beds and then times 100. It is a ratio, it's a proportion, so it is in percentage. However, uh, this calculation might not be a linear pattern the way it looks because we are looking at the number of beds we have and also the duration that patients have to occupy this bed before they are discharged. And this one varies between one person to the other. Others can stay long depending on their situation, maybe trauma cases, orthopedic cases. But if this is maybe an admission for malaria, we know it doesn't take quite long, 3 days, even 2 days, somebody is already charged on oral medication. So we shall have an example in the next slide to see how we can look at the cumulative days and to apply this formula as practical as we can in the same scenario we do in the wards. The implications, we have high bed occupancy rate may indicate a strained capacity and potential issues with patient flow and access to care. So basically, the bed occupancy rate will always tell us many things in our planning process. Okay, it could indicate issues with patient flow or even access to care. For example, if we have definite criteria for admission and discharge, okay, we need to have that best assessment to see is this person really worth staying in the hospital. But at the same time, we also need to avoid discharging patients before they are due to be discharged simply because we are running out of beds. So all these kind of things need to be taken into consideration so as to keep the balance. So let's look at this example to help us understand more perhaps. For example, you have to calculate the bed occupancy rate for a period of 1 week in a hospital with a bed capacity of 50 overnight stay beds and patients accumulated bed days of 330 days. So basically, what this question is trying to ask us to do is that we are calculating the bed occupancy rate for a period of stay for 1 week. Okay, we can actually do this for a period of 1 day. We can even do it for a period of 1 month. We need to see for this period of 1 month what was the bed occupancy rate, or we can even do it for the whole year. Okay, but here our question is talking of 1 week, And then they have given us the bed capacity. We only have 50 beds. So we have our health facility. This is the maximum number of beds we have. And we also have the accumulated bed, bed days of 330 days. What is the meaning of this? The accumulated bed days of 330 days is already the summation, as I told you, is the total of all the days patients spend on this bed added together. Those who are admitted for 1 day, those who took long, like 1 week, those even who might have taken more than 1 week, depending on the cases we handle. We sum these ones up, so it's telling us that this is the summation we have got. So the bed occupancy rate using our formula will be given by the total, the available number of beds times the days in the period, and then times 100. Once again, it's the total number of days or bed days divided by the available beds times the days in the period, and then times 100%. So substituting this in the formula, we have 330, which is our bed days, divided by 50 is the number of our beds, then times the period we are measuring. This time we have 7 days. 1 week is 7 days, so this 7 is for the 1 week, and then times 100% is giving us 94%. So this one tells us that actually for this 1 week period, 94% of our beds are occupied. And if we anticipate that perhaps we are going to get more patients by next week, maybe because we are entering already something we predict like the malaria period, then that means already our 50 beds are already constrained. Anything can happen here, and only 6% is remaining. We can go to over 100%, and that means we may need really more extra beds. So this value is important in help us understand and make better plannings. Okay, measuring hospital capacity. Number 2, we are looking at the throughput. The throughput measures how efficiently patients move through the health system from admission to discharge. The indicators for the throughput are the length of stay, which is the average time patients spend in the facility. The discharge rate, this one is the rate at which patients leave the facility. Okay, like every day, how many do we discharge? There's also a formula for this, which is the number of people discharged and divide by the number of beds. The discharge rate. You can check on it, and you can get more on that online. There are available resources on this. Implications: efficient throughput reduces bottlenecks and ensures timely care delivery. Waiting time. Waiting time is the time taken for patients before they can access healthcare services. This could be appointments or even the time needed for doing a procedure. Okay. Indicators, we have the average waiting time. So what do you mean by average waiting time? Already, when we are planning our project for every given health facility, when we are trying to apportion the number of staff, we are already factored in all these factors. Okay, we want that at least a patient will not stay longer in the facility. So perhaps the average time flow between entrance and exit, if we say it will be at least 30 minutes, then we need to really figure out how how can we exceed that by taking uh, all the patient flow and also the needed number of staff that we need to have them in order to be able to meet this efficiency. Okay, so already we already have an average waiting time, which depending on the procedures that this person is going through, at least we said it shouldn't uh, be something too long, like somebody spending more than 1 hour or even 2 hours just to get treatment. It may discourage patients. Also, we look at the percentage of patients seen within the targeted waiting times. Okay, so here, assuming we say that in our facility, by all means we want by 30 minutes, at least a person has been seen as the average time. But we also need to say, okay, if that is the average time we have defined, but how many persons are actually seen within that period? So that is not the percent of persons seen within that period. So we are trying to see uh, how best what we have set into place is really achieving its goals. So the implications can be excessive waiting times lead to patient dissatisfaction and delayed care. And again, as I've said, when patients felt dissatisfied, sometimes they will not come to the facility because they think that they will be wasting too much time, especially for patients that are not really in pain. They will just always not come to the facility. They always wait until they deteriorate. When they feel the pain, that is when they will come because they feel that I have other things to do and maybe I can manage. So we have quantitative data techniques for measuring hospital capacity. We are going to look at the three of them. One is we can do it by gathering the historical data. We can also do an analysis of the data trends and the patterns, and then we can also look at predicting the future demand based on this data. These are actually statistical methods that we use, as we previously mentioned. So looking at gathering the historical data, we look at patient admission records, okay, and then we look at the length of stay, and then also the patient demographics. So here we are looking at exactly how were events. First of all, if we need to understand, we look at what record does this facility have from last year or even from previous data. Okay, how many admissions in the last month, for example. Okay, and then what was the average length of stay, for example. And we also look at the patient demographics. Patient demographics, we know that age is also a factor, where mostly, if we take the advanced age people, most of them already present with chronic conditions. Someone coming to the facility with chronic condition will always have a longer period of stay. Okay, someone with hypertension, someone with stroke, these people may not have the same length of stay as compared to someone coming with malaria. Okay, 2 to 3 days maybe is discharged already for outpatient kind of home treatment. So all these kind of demographics will show us what we are expecting. Okay. Okay. Now we look at qualitative data for measuring hospital capacity. We have looked at quantitative techniques, which we said mostly we employ statistical methods basing on our data that are already in the registers. So qualitatively, we can do what is called expert opinions, and then we can do stakeholders interviews. Okay, we interview uh, those who are involved in delivering the care, also including even community representatives, because we know that the community is also part of our hospital care. Otherwise, if we are providing care and we also don't understand the community needs, then that means we are not really knowing what is also keeping our patients not from not accessing the services that we are providing. We have what is called a scenario planning. We shall talk shortly about it. The diagram on the left is about a scenario planning. So about the expert opinions, we have two methods. There is what we call the Delphi method and also expert panels. So the Delphi method uses, I mean, it relies on opinion. So it's like a kind of trying to conduct some kind of interviews with expert people who are already technocrats in the health system management, and then we discuss with them in depth, look at problems, look at the solutions, and then come up with those solutions, and then we can do it repeatedly. At the end of it, we shall already have concrete kind of findings that are enough for us to use as a technique to approach the issues we are facing. Our expert panel is the same, but here we just bring experts together and then discuss, deliberate, on what best we feel we can do, and then ideas are tabled, and then it's implemented just once. There's no repetition like in the Delphi method. So let's look back at our scenario planning. So like this is a tool. This is a tool to maximize our planning techniques. So we look at what scenarios will give us high impact and which ones will lead to low impact of our intervention. Which ones will give us high probability of achieving what we intend to do, and perhaps which one will hamper, which one will affect. So we are looking at both the positive and the negative aspects. So the point here is to be able to plan on how best we can improve on the positives and also how best we can minimize on the negative, because we already know scenarios that can improve our health facilities performance. We also know situations that will lead to reduction. Okay, so this is the basis of operation of this scenario planning. So let's see the four quadrants here. Okay, between the high impact and the high probability, we have the strategic shift. Okay, so this is what actually will give us a strategic shift, which is a positive uh, impression of what we intend to achieve. Okay, high impact and high probability. But let's look down where there is high probability. We can be able to predict that things will happen this way based on the parameters we have, but where we also think that the impact will be very low. So this one will give us the incremental change. So we have strategic shift, we can have an incremental change, but sometimes we can have flaws in the plan, okay, where we anticipate low probability of events occurring, and then also with a very low impact. So this one will have a flaws in the plan. That means there is already a disruption. We might not expect to get things the way we strategize initially in our project proposal for this quality of care deliverance in this hospital. And then here, between the high impact and also the low probability, you have the major disruption. So you see, where now we anticipate low probability of occurrence of scenarios, and then we expect high impact. There's already a major disruption of what of our presumed planning. So this is how scenario planning can be used. Okay, let's look at factors affecting capacity. There are quite a number of them. So let's start with number one, which is variability, and number two is uncertainty. So let's look at variability. This is variability in the patient arrivals, disease patterns, and resource availability can challenge the capacity planning. Okay, for example, if we used to receive like in the outpatient or even in the inpatient, maybe we used to receive like 200 patients every day. Okay, 200 patients is a range, it can be 200 to 300, but all of a sudden you find in one day you are receiving like 500 plus. Okay, 400 to 500 plus. Already, this is a variability that even the system had never been used to. The person in the outpatient even will get surprised that this is not the number of patients we used to see today. I mean, previously. So what is happening today? Already, it affects the whole system. Okay, and then the disease patterns. Different diseases might also affect the health system differently. For example, I can still use COVID-19 here. We saw how it affected and changed all the patterns. Actually, other diseases by that time were not paid attention into. Okay, and then the resources availability. So whatsoever the case, ideally we are supposed to have enough resources to be able to cope up with these changes that happens without expectations. But many a times also it's not easy. Our health systems are not flexible. We don't have all those resources. Uh, we are giving some examples here like seasonal flu outbreaks, where you see many patients will be coming to the facility, okay, with almost similar symptoms, and then unexpected patient surges or unpredictable admissions. I would like to say something about unexpected patient charges. For example, those who had been in South Sudan, especially, we had been exposed to quite a number of humanitarian situations that happen. You know, a displacement happens, and then people move from one area to another. Uh, what happens is that where more people have moved into a place where there's only one health facility, expect that already that system is constrained because the sick people that will be coming to this facility will be more than already the plan, threshold that this facility is supposed to handle. Okay. We look at uncertainty arises from unpredictable events or conditions affecting healthcare demand. We already mentioned about COVID, emergencies or disasters. We have flooding in the northern part of the country, all those kind of things, uncertainties. So health facilities are supposed to have contingency plans to handle uncertainty. This is a big issue, especially for most of the NGOs. Sometimes they can have a contingency plan based on already experiences they had, but sometimes even the disaster happens to the level that the response needed is more than this particular contingency plan that they have in place. Okay, and then the same applies to the National Ministry of Health. All these facilities are supposed to have this contingency plan so that a rescue can happen, because always we live in a world of uncertainties that our health systems should be prepared for. Number three, we look at seasonality. Seasonal variation in healthcare demand can strain capacity during peak periods. Okay, increase utilization during peak malarial periods is an example we are giving here. For my experience working with malaria, especially in Uganda and also South Sudan, normally when it reaches July, sometimes even late June, and then July we get the real peak of malaria. I remember there was a time where we just got a more than 100% bed occupancy rate in one day, simply because we had entered the malarial peak and we still don't have enough capacity. We don't have enough beds in the hospital. This one called for an emergency resources mobilization, and we were able to stock a number of beds to be able to accommodate. Otherwise, patients were already admitted on the ground, children, and it is quite uneasy because it compromises the quality of care. You can't be able to adjust a better mosquito net on a patient that is admitted on the floor, first of all. So it's a bit challenging. The same in South Sudan. We normally have two peaks, one in July and another one in October. So you see that all this kind of seasonality, if it is a regular pattern, especially like the malaria kind of thing, we can be able to prepare in advance. And this is where we can perhaps be able to predict. But the problem, there are others that we cannot predict. Okay. We also have example of trauma cases in summer months. So maybe this example is more practical in the West, where during the summer, this is a time where actually people have holidays. Most of the schools close in July, and this is where, yeah, the sunshine, the winters have gone, and everyone is traveling. It's a time to enjoy. People move a lot, but also at the same time, because of increased traveling, it's also associated with trauma cases from maybe road traffic accidents. So these are seasonal things that always we can predict. A common one also in line with this, basing on my clinical work experience, especially when I was in Western Bargazal, we used to receive a lot of trauma cases. I mean, during fruiting season, when the mangoes especially are getting, to when they are getting finished, or the period when mangoes are getting finished, we receive a lot of young boys, young girls being brought to the facility. Just as a case of a fall from tree, in a month we could receive either 3 or 4 children from a primary health care unit, which has no facilities to manage this case in terms of radiology demand, no X-ray, and then these cases have to be transported long distance. up to Awil Hospital for X-ray and further management. So you see, all these are kind of things that always it can make us plan in advance at our health facility, because we need to have the referral system functioning an ambulance. We need fuel. We need quite a lot of resources. Demographic factors and aging population often requires more healthcare services. I already briefly mentioned about this because of the risk of chronic illnesses. When we become age, our cells are getting tired, and many chronic sickness come in: hypertension, stroke, many other things, including extended hospital stays and also a complex care. Rapid population growth in certain areas can strain healthcare resources. What determines rapid population growth? It could be immigration, all right? More people are moving into the area, like what we are seeing right now with influx of refugees from Sudan, okay? At the same time, um, okay, increased fertility rate is one, but also this one is balanced by a number of deaths. So if there is high increase in fertility rate, and then maybe an increase in number of deaths, also in a certain period, we shall be expecting already the population is growing. So that means that even our health systems are also supposed to be, you know, adjusting to this kind of changes, so that it is able to provide the needed care. Otherwise, population is increasing and healthcare capacity remains the way it is, meaning already people will soon not be getting the quality that we define to be provided by this project. Number five, economic factors. Economic factors can affect people's access to healthcare services, leading to variations in demand for different healthcare facilities. Changes in health insurance coverage or healthcare policy can influence healthcare utilization. Well, I will still repeat. South Sudan, we don't have a national health insurance system, okay? But already we have the social health insurance system. Some of you who might have got insured by these health facilities, I mean, by this insurance company, will agree with me that even the insurance company specifies the package of healthcare that they are going to provide for you and your clients. Okay, they don't go into other things. For example, the insurance company that I was covered with when I was one of the NGOs clearly mentioned that we are not going to take care of elder people, but we are taking care of people from 18 years and below. Maximum of 5 dependents for your spouse, and then 5 children below 18 years. Why that? Because already this is a business, and we know what will happen to this insurance business when we include those at the extreme age, the elderly. They are at risk of chronic disease, so that means already the business will not work. These people will be, you know, frequently admitted, and their bill is always so high. So that's why they do this. But at the end, already this is something that has influenced the way someone can access care. Okay, even they mentioned clearly that they don't take care of other diseases like cancer. They are not part of it, because we know what cancer can do and how much spending the family might go through. Even rheumatological conditions, these are chronic conditions. They are not part of the inside. So you see, all these are socioeconomic factors that will influence people's health. Okay, we look at technology and innovation. We said new medical technologies and treatments can impact capacity by increasing the complexity of care and reducing hospital stays. So we are at an era of increasing healthcare technology, okay? Especially the radiology department. We have many diagnostics that are emerging, and they are really helping us to provide healthcare at, at a better level than previously. Okay, if we look at our healthcare systems right now, and maybe like 2 decades ago, you will see that we have moved a step where treatments can be done quickly. Okay, we have the ultrasounds already accessible in most of the facilities, even including primary health care centers here in Juba. We have the X-rays, we have CT scan, MRI. These were things that used not to be at a nearby facilities. So that means already a delay happens because perhaps you need first of all to get this diagnostic report before this person can get a better diagnosis, which is perhaps long distance away, a lot of referrals. But yeah, the innovation has improved many uh, most of uh, the way we provide services and a reduction in hospital stays. Telemedicine is a kind of like online consultation or even diagnostic criteria. What happens here is that, for example, you are in your health facility and then you are receiving patients, but then you feel that there's a patient you don't have the capacity to diagnose. You can, with telemedicine, you can talk to a consultant online. For example, I was working in a facility, and then a person was brought, but then this person had some ophthalmology related kind of presentation, which I feel that he needed a better assessment of a specialist ophthalmologist. So what we did was we have a group of ophthalmologists in Paris. Okay, so consult him online, give him the patient detail, even take photos of the patient, we even call him, we discuss, video call, everything. Already from there, he was able to reach exactly a diagnosis that was far better than if I would have made alone, because he is the expert in that area and he understands it better. So telemedicine actually in the Western world, some countries have already taken it as part of the national Ministry of Health strategy. Okay, to be able to attend to patients, because it minimizes waste, it minimizes too much movement of patients already going long distances just to meet a consultant. But of course, it goes with the level of internet we have and all those access things, which might also be a challenge if there is no access bill. But still, it is something that we can do in South Sudan as well. Regulatory and policy changes. Changes in healthcare policies, regulations, and reimbursement models can affect how healthcare facilities operate and plan for capacity. So we all know very well that the way health facilities are regulated and also the way policies are implemented has an impact at how healthcare services are provided to the population. Okay, in some countries already we have what is called the performance-based financing, where you are given the health facility and the staff are given a set of targets to meet and a certain quality to meet, of which this quality, if it is not met with 70 or 80% target, you will not get paid. Okay, the staff, you will not get additional. It is an additional pay that they give us to motivate. So you will not get this money. Even the administration will not get this additional money. So you find now healthy personnel work very hard to sustain the quality, and actually it has been one of the quality assurance technique that is working in health facilities. Okay, so these are part of regulatory techniques that can be used to achieve the quality we want, performance-based financing. Social factors like housing, income, and education can influence healthcare needs and suggestion. So it has actually been proven that people who cannot afford treatment cost many a times will not come to the treatment. They feel sick, but they don't want to go to the hospital because they fear, what am I going to do? What am I going to face? Okay, especially where consultations is paid for, treatment is paid for, even laboratory is paid for, like our current situation even in the government health facilities, it's not for free. So these kind of things makes people feel that they are not, they don't need to go to the facility, and they find they only come when really, really they are deteriorating and unwasted, when even things are a bit difficult. So social determinants of health is one of the major issues that always affects communities when it comes to seeking of healthcare. Okay, geographic location, healthcare capacity challenges can vary based on whether a facility is in a rural or urban area. Let's take, for example, in South Sudan. Outside the context of Juba, or maybe the main towns like Wow or whatever, just go deep to the rural counties and see how much distance every day some families have to travel before they get to the nearby health facility. It's really a challenge. Some people move on bicycle almost nearly the whole day before they can reach the health facility. Okay, resources availability, staffing is one of the most important thing. If we need to achieve the quality we want, we also need to make sure that we really have adequate staff. If we need to make sure that these waiting times, these waiting queues are avoided in the facilities, then how we need to know the staff, and the ratio between our staff and the patient. Is it really the adequate ratio? Otherwise, of course, the time will go, because you don't also, it's not matter of seeing the patient and the patient go, you also have to take the necessary basics. So sometimes it becomes difficult to balance if we don't have adequate ratio of staff to patients. Okay. Equipment and supplies, very important. Okay. Somebody comes to the facility, is consulted, at the end it goes back without drug. What will be the meaning of that? We don't have enough supply, we don't have drug, we don't have everything. It is actually more frustrating the patient. Will not even come back again next time. Availability of critical medical equipment and supplies is essential for maintaining the capacity. Capacity planning and management. Effective capacity planning and management involves, one is forecasting the demand based on historical data and trends. So remember, we said at the start that one way of trying to understand this is look at the previous record. Okay, we make analysis using statistical models, and then we shall help forecast what is the demand. Okay, if last year this was the number of people admitted, and then during malaria peak it went to this, what are we expecting this year? Okay, and then we can even look at the trends and project from there. Adjusting staff and resources to match expected demand. Already we discussed this. Collaborating with neighboring facilities during capacity crisis. I would like to give an example here. Uh, we had uh, we had a crisis in Iba County. Okay, but at the time I was in Maridi County. So what happened was there was a deworming program where uh, they were giving this drug praziquantel to mostly school age children. And then the team went to the school, but I think there was uh, a miscalculation in the weight uh, and the ages of the children, and some of them received a high dose of praziquantel, not relevant to their age and weight. So almost the whole school was admitted, 300 plus, not actually one school. There were quite a number of boarding schools. So this was given in a boarding setup. All these students were transported to Maridi Hospital. There was no enough space. People were admitted up to outside. So what happens in this situation? You need help. Already the available staff are not enough. Okay, so you need to collaborate with nearby health facilities. And at that time, even not just any nearby health facility, we even had to look for some volunteers that could be given uh, some quick training to be able to help in other aspects. Otherwise, the human resource is no longer enough. Okay. Capacity planning methods and models. Capacity planning is crucial in healthcare to ensure services can effectively meet future demand. Various methods and models estimate demand and supply and evaluate the scenarios. Capacity planning methods and models provide healthcare organizations with data-driven insights to make informed decisions. They support efficient resource allocation, improve patient access, and cost-effective services delivery. Now, we shall look at them one by one, okay? The capacity planning methods and models. We have about 6 of them: demand forecasting, scenario analysis, resource allocation models, queuing theory, simulation models. We talked already about simulation models. If you can reflect back to the first lecture, where we said we use them to make sense of real life scenarios, but we use statistical computerized models to make sense of that real life scenario so that we can understand it more. Number 6 is healthcare facility allocation models. Okay, let's look at number 1, demand forecasting. Demand forecasting uses historical data, trends, and predictive analytics to estimate future patient demands for healthcare services. So you have already analyzed the previous records of this hospital based on the data. Okay, so here we look at the trends and then we can use them to predict what might happen in the future. Okay, they can be of the 3 categories. You can use the time series analysis. There is also what we call a regression analysis, and also the machine learning algorithms. All these are statistical models. On the right is an example of a time series analysis graph that was used to analyze global temperatures. You might be aware that we are already experiencing global warming because there is continuous increase of carbon dioxide in the atmosphere due to human activities. Industrialization factories are polluting the atmosphere, including even household carbon dioxide concentrations. So let's look at this graph. This was a graph relying on data from 1860, okay, almost a century, actually almost 2 centuries ago, and then up to 2020. Now, let's look at the pattern of the graph, okay. Generally, it has a positive slope, telling us that continuously our activities are contributing to increase concentration of carbon dioxide in the atmosphere, okay. What we have here is the global temperature. So it is actually increasing, and that's why we are now faced with a lot of disasters. Okay, there's flooding, there is drought. So all this graph helps us to predict what might happen in the future, and that's why we are crying a lot about what can be done. Otherwise, we are continuously increasing this temperature, and we shall continue to see more disaster. A scenario analysis. I already mentioned about this. You can reflect back on our previous slide. A scenario analysis involves creating multiple possible future scenarios based on different assumptions and variables. Okay. Uh, it helps healthcare organizations plan for various possible futures and develop strategies to handle each scenario. Resource allocation models. These models determine how healthcare resources like staff, equipment, budget are allocated to different services or departments. Again, these are statistical models. Okay, example is we can use the linear programming, we can use integer programming, and we can use the global programming. So this one works on the basis of, like, we have already a parameter that that 2 parameters that we need to see how this parameter will be affected, maybe with time. Okay, and then we look we shall use the programming. It will tell us how the change in one of the parameters, either the dependent or the independent variable that we are measuring, will be affected by time. For example, if our independent variable is time, and then we have a parameter maybe like the number of staff, these programmings help us to see, Okay, what will happen with time to our staff? For example, like the scenario in Sudan currently, there is already a war that is happening, and most of the staff that were in the health sector, according to reports, most of them are already leaving the country. Others are going to Europe. So if these scenarios continues, okay, what do we expect of the staff? Already, this is something that we can be able to predict. Most of them will be going out of the country, and already we are not expecting. What if the situation reverses? So all this kind of programming will help us have a clue by looking at a factor and a variable, and how the variable will be affected once it is exposed to a given factor. Okay, we look at the queuing theory. Queuing theory models patient flow, is waiting times and service efficiency by analyzing queues or lines of patients. So this is just all about looking at the patient flow, and you see the queuing. Why people are so congested, the line is not moving, and you look at all the pathway as we already discussed previously, while also trying to really understand why it is happening and how best we can be able to solve this at all the stages of the patient's pathway. It is applied to optimize appointment scheduling, reduce waiting times, and also improve resources utilization. Simulation models replicate real-world healthcare processes to study the effects of changes and intervention. The benefit, they allow for experimentation without real-world risk, and are used for capacity planning in emergency departments, surgical units, surgical suites, and also other areas. Health facility location models. These models determine the optimal locations for healthcare facilities based on population distribution and demand. Already we know that before the government actually will think of bringing maybe a primary healthcare center or unit to an area, they first look at what is the population there. Okay, what is the size of population there for us to be able to provide this particular service? Does it need a hospital? Does it need just a center? Does it need? Okay, so there are already population parameters that always they use. Applications is used for planning new hospital, clinics, and healthcare centers. I already mentioned this. Also, another example here could be, if we look at actually the current World Health Organization um, framework in terms of how far a household lives from the health facility. Actually, they are saying at least a household is supposed to live 5 kilometer diameter to the nearest health facility. The challenge is that, well, maybe in the urban settings like Juba, we can still have this, but it might not really be the case with the government facilities. Maybe with private, it also has its own cost constraint. But how do we make sure this is achieved in the villages? It is quite not easy. Families travel quite a long distance. I've been in Western Baragazal where people move on bicycles, sometimes the whole day before they reach the facility, bringing a pregnant mother, maybe for labor. So you see all those kind of challenges. Well, we have bed capacity models. Bed capacity models estimate the beds needed to meet the future demand based on population growth, disease prevalence, and patient demographics. We can reflect back already to our bed occupancy rate, plus the others that I already mentioned. These are important tools that can help us plan uh, the capacity. I mean, yeah, the bed capacity models for future use in the health facilities. They utilize mathematical and statistical methods to project the bed needs. Evaluating scenarios and alternatives. Capacity planning models help evaluate different scenarios and alternatives by assessing their impact on patient care, cost, and resources allocation. The metrics it uses are cost effectiveness, patient satisfaction, and resource utilization. Actually, these are the three things that we shall be monitoring. Okay, we shall be evaluating in these scenarios. How effective is this intervention cost wise? Okay, are the patients satisfied with this quality? I mean, with the service that are being provided. Is it taking too many resources, or is it taking as optimal resources as we could? Because this was, remember what we discussed last time, to be able to provide the quality care with optimal use of resources. Okay, we have come to the end. Thank you so much. Thank you for being with me, and see you again in the next lecture. Bye bye.